There's a difference though between radiofrequency and microwave. Radiofrequency can work very well in many cases and can have good results. And Ms. Susette had actually a reasonable response. She had like a 50% shrinkage, but the nodule was extremely vascular, but it started to regrow. So this is when we decided we really need to try another modality, which is microwave. It is very well documented that with microwave, you can deliver more energy safely, but there is an effect called the heat sink effect. With radiofrequency, the vessels will absorb the heat significantly in radiofrequency compared to microwave. So you can deliver the energy and keep the energy working for more time. And in this case, literally just 3 months after the treatment with microwave ablation, the volume reduction rate, the shrinkage happened to be 80%, which was extremely impressive compared to the prior radiofrequency ablations.
It did shrink, for the first RFA, but came back being stubborn. The second time, same thing, and I could see the look on his face. He was disappointed that it was coming back, and then we said, okay, we'll do the microwave RFA, and that seems to be the way to go. I'm happy about it, but and I will say this: if anybody is watching this and they're afraid of it, don't be. It's not painful at all. You wake up and you feel fine and no pain, and you go home.
It takes a while for the medical community to accept new interventions and novel technologies. But this is not investigational anymore. This is very well studied. This technology has been out there for a couple of decades outside the United States, and we've been doing this in the US for 5 years. And patients deserve and have the right to know their options. And still some patients require to have surgery, and surgery is the only option. But many others do not need an operation.
Hello, everyone. Welcome. Philip James from the Dr. Thyroid podcast. And today's guest is a patient, Susette, and her doctor, Dr. Kandil. We're in New Orleans, Louisiana, Tulane. And today we're talking about microwave ablation. But we're also talking about radiofrequency ablation. Because why? Because Susette had radiofrequency ablation for a thyroid nodule.
Yes.
The response wasn't so successful. However, after 2 times of treating with RFA, Dr. Kandil treated her with microwave ablation, MWA, and it was very effective. Mm-hmm. And we're going to learn a little bit why, and we're going to learn a little bit about Susette's experience as a patient. And before we start with any of the technical side, Susette, you went to a surgeon.
Yes.
Before seeing Dr. Kandil.
Yes, I did.
And
he wanted to cut it out.
He wanted to cut it out.
Yes.
So tell us about that experience.
Well, I think he knew I was a little apprehensive about having my thyroid removed. And he actually recommended Dr. Kandil, that he had heard about Dr. Kandil and that he had a new technique in removing the thyroid. So he just assumed the thyroid needed to be removed. But after seeing Dr. Kandil, he's like, wait a minute, we can do this RFA, give it a try and see what happens.
So how did you know you had a thyroid nodule?
Well, my cardiologist found it in a routine carotid artery, ultrasound. And I guess they went off course and got to the thyroid, and that's how it was found, and said, see your internist, who in turn sent me to a surgeon, and then I found Dr. Kandil, which I'm very happy about.
Yes, center thyroid.
Yeah.
But why were you in for the cardiologist? There was an ultrasound?
No, it was just a routine checkup, and they just were doing this ultrasound, I guess it is, for the carotid artery, and whoever was doing it evidently went further than they had to and got to the thyroid and found it.
Can you tell us that experience when they said, listen, while checking, for your heart. We found this other issue.
Yes.
How did they present that to you?
Well, they just called and said you might want to see your internist about it, and this is what it is. And so that's what I did.
And what was your emotional response when they told you have this growth?
Upsetting. The first thing you think of is cancer, and I don't know. I was kind of surprised by it, actually.
And then how soon did you schedule an appointment with a thyroid doctor?
Right away. Well, yeah, right away. We went to the internist, and within a couple of days we saw the general surgeon, and he sent me to have a biopsy, but it was a different doctor, and it was in a hospital setting. That was another thing. Hospital setting where you're under anesthesia, and they, couldn't say one way or the other if it was cancer. And that was another thing when I found Dr. Kandil and had my first appointment, and he says, well, okay, they did the ultrasound right there, and he says, well, we're going to do a biopsy. And I said, well, when's that? And he goes, well, now. And he does it in the office.
With Dr. Kandil?
Yes, with Dr. Kandil, right there. No anesthesia going to the hospital or anything like that, which was wonderful.
Can we backtrack for a moment on this
Sure.
experience? And then we're going to get to Dr. Kandil
Okay.
and why and how he chose to do the biopsy in the office
Mhm.
and more details about MWA. But going back to your hospital experience, you just said you weren't sure if it was cancer.
No, they weren't sure.
Well, how did they present that to you?
Just that they took, I don't know, I guess they're small pieces they take and send
Mhm.
off for biopsy, and they couldn't be sure if there was cancer or not.
And what was the emotional experience like when you were told, we don't know if it's cancer?
Well, that was another reason I needed to find somebody else to look into it, because it is a nerve-wracking thing,
Were there any tears?
No, I don't know.
Not that much fear.
No, I wasn't too afraid. I guess I felt fine, and didn't seem to think maybe it's not a serious thing, but it's always in the back of your mind that it could be.
Okay, so now, fast forward.
Okay.
You're told you have this nodule,
Yeah.
and your surgeon's saying, let's take out half your thyroid.
Yes.
And then you say, this doesn't sound very good.
No.
I'm going to research another opinion.
I would like to intervene here before going into the other opinion. So what's important here to highlight that yes, Ms. Susette, she did have a mass, and the biopsy showed some suspicious cells. Traditionally, yes, the standard was to do surgery to take it out because it could be cancer. But it's been over a decade now where we have panels, genetic marker panels, where we can tell if this is cancer or not. And to tell a patient you need surgery just because it could be cancer or not, it's kind of really ridiculous at this point, at this day of age in USA. We have, genetic markers and panels that are covered by insurance that can give us an idea about really the risk of malignancy. If you decide as a physician to do that test out of the bed, 2/3 will be benign, do not need an intervention, and 1/3 can be suspicious. So the patient deserves to have this information. And as a treating physician, if you know that this is definitely cancer, then I'll give the patient one good operation. Not just take that lobe and see if it's cancer or not. I'll take the whole thing and maybe remove the lymph nodes around that thyroid and give the patient one good surgery. Not, let's take it out, see if it's benign or cancer. If it's cancer, we need to go back, remove the rest of the thyroid, and multiple general anesthesias, multiple operations, redo surgery, have a high risk of complications. So even if it's a bad one and needs to come out, you need to have all the information before proceeding it. Well, in this case, which was, again, as I said, 2/3 of the patient will have evidence of benign genes that requires no risk of intervention. Ms. Susette has benign genes. So that was the good news. Having said that, the mass was large and was like over maybe 100 ml and was very vascular. So you worry about maybe we're missing areas that has something. So you can argue, well, we maybe need to consider removal. But now we can talk about the innovations and the new technology to also keep the thyroid.
The mass was large. How large?
So I like to look at it when I talk to patients. They look at centimeters and stuff, but honestly, we need to look at the volume. This is how we measure things with a 3-dimension. But so you look at the width, length, and height of the nodule, and in her case, it was like over 100 ml.
Mm-hmm. One pause for any of the patients watching this video. If they're being told to have surgery, this is a reminder
Yes.
to seek out a second opinion.
Yes,
Right?
they should. They
And
should.
find a doctor. And I think what's interesting about Dr. Kandil is he's a surgeon,
Yes,
and he really advocates against surgery
Yes.
if it's possible, if
Yes.
it's in the best interest
exactly.
of the case and the patient.
That's right. He'll do anything to save it if he can. I believe that.
So with this video, it's about how your initial treatment was with radiofrequency ablation, RFA.
Yes,
You in fact had 2 treatments with RFA.
yes,
And eventually you got treated with, because the RFA wasn't showing response, you eventually got treated with
Yes.
microwave ablation. Dr. Kandil, can you walk us through that?
So both radiofrequency ablation and microwave ablation are considered thermal ablation. Both deliver a heat energy, and this heat and this energy will cause necrosis, which means death of the cells. And eventually the body will absorb these cells and the mass will continue to shrink. There's a difference though between radiofrequency and microwave. Radiofrequency can work very well in many cases and can have good results. And Ms. Susette had actually a reasonable response. She had like a 50% shrinkage, but the nodule was extremely vascular, but it started to regrow. So this is when we decided we really need to try another modality, which is microwave. It is very well documented that with microwave, you can deliver more energy safely, but there is an effect called the heat sink effect. With radiofrequency, the vessels will absorb the heat significantly in radiofrequency compared to microwave. So you can deliver the energy and keep the energy working more for more time. And in this case, literally just 3 months after the treatment with microwave ablation, the volume reduction rate, the shrinkage happened to be 80%, which was extremely impressive compared to the prior radiofrequency ablations. So I promised Ms. Susette that, right now we are very happy with the news, with the biopsy, with the mass shrinkage, and definitely we are not going to operate, and she is going to keep the thyroid. So I'm a surgeon. I've done over 5,000 of these operations. This is what I do for a living, and I love to do these operations. It just I'm in the zone doing this. But I really care about quality of life. And Philip, you know this. Even in the hands of excellent surgeons, there are always possible risk of complications. But even with zero risk of complications, in some cases, I literally can tell the patient, 0% complications or your money back. I can almost guarantee in a lot of cases that. Having said that, it's not just about the surgical complications. It's about the quality of life after. If you remove the thyroid or even part of the thyroid, patients might never ever feel good again. They might never feel themselves again. The energy level, despite that they are complying, they take the medicine on time, their blood work is normal, they might never feel normal again. Because nothing like the hormones that comes from our own thyroid, from the factory that God gave us. So, and this is very well documented, very well studied. So I think, and then no general anesthesia, no risk of complications, no cutting, no worries about thyroid hormone replacement or how you're going to respond well or not. I think everybody should deserve that chance.
Wow. Now, Dr. Kandil, in regard to the treatment of Susette with the RFA, and it was halfway successful. You said there was some reduction. But would there have been a case if a doctor didn't have an option to also offer MWA and get even better results? Would there be a case if all they were using was RFA where maybe then they would say, let's do a surgery?
Definitely surgery continue to have a role in advanced cases, like in advanced cancer cases. We still offer ablation for early cancer, smaller cancers, but for advanced cases, for large substernal goiters that we still can treat, by the way, with some thermal ablation, but in these cases, maybe surgery will be definitely helpful. In cases with Graves' disease, surgery, so there is still, I still do a lot of operations. I'm still very busy surgeon with thyroid surgery, but definitely the thermal ablation technology with radiofrequency or microwave provided really a new opportunity for patients to keep the thyroid and avoid the need for intervention with surgery. And there is advantage and disadvantage for each one. But here we can see that there are options, and we have many patients like Ms. Susette who tried radiofrequency in many other places, many other states. Actually, most of our patients are out-state patients, and they know now about this, and they're asking, and they want to try another opportunity. And this is a very good example that one option might work a little bit, but other option can be really the answer and the solution for this.
What was your response when you came to see Dr. Kandil? He said, we don't have to do surgery.
I was thrilled. You know, I just felt relieved that if we can do it without the surgery. I was afraid that, because you hear all these stories of people who have to do the hormone replacement because of the thyroid being removed, and as Dr. Kandil just said, their lives are not the same because it's hard to regulate, and that really worried me. I didn't want to have to do that, but when he said we could try this, I was all for it. I mean, it did shrink, you know, for the first RFA, but came back being stubborn. The second time, same thing, and I could see the look on his face. He was disappointed that it was coming back, and then he said, okay, we'll do the microwave RFA, and that seems to be the way to go. I'm happy about it.
What would you tell your friends who have a thyroid nodule?
See Dr. Kandil.
And then what did you say if they went to another doctor?
She's gonna bring all her friends with thyroid nodules.
What would you tell your friends who got treated with, they had a thyroid nodule, they didn't come see Dr. Kandil, they went and got this new trend that they're hearing about, radio frequency, there was no shrinkage, or a little bit,
Yeah,
then what would you tell them?
go see Dr. Kandil for the microwave RFA.
Yeah, I think that's important, and I think the reason I asked that question for patients watching, not all information is equal, not every surgeon is equal,
Right,
not every surgeon has a toolbox of not only an approach of let's avoid surgery if possible,
right,
let's maybe do active surveillance, let's maybe treat it with ablation, but depending on the case, we're going to choose RFA or MWA.
yes, yeah,
You know, the toolbox, or if you need a surgery, like Dr. Kandil said, he said he loves to do thyroidectomy. Not that he loves to take it out,
no,
because he approaches his surgery as a craft
yes,
and perfection. And that's the kind of love that he's treating you with love.
yes,
But he's offering a full toolbox. And I
Yeah.
think it's important for patients watching
yeah,
that when they're being faced with a thyroid nodule, that they find someone, if not Dr. Kandil, who approaches this kind of treatment with an open mind
yes.
and not just one option, which would be
Right.
surgery.
And I think that's how it should be, you know, with an open mind. And even if they're not sure about what to do, you know, find someone that does for that person, you know.
Was there anything different about your experience? You said it was uncomfortable when you went to the first surgeon. They did the biopsy, the
Yeah.
result wasn't right away. You were in a hospital setting,
Yeah.
felt kind of cold and the sterile.
Well,
But then you came here.
yeah.
Can you talk through kind of the contrast?
Well, the first time you're in a hospital setting, it made it seem more serious than I think it was. You know, it made you more afraid,
More
I think.
anxiety.
Yes, more, that's the word, anxiety. And then coming here and they said, well, we'll do it right now, right here in the office. It's like, how's that possible? You know, it made me think, well,
Was there a difference in how actual interaction with Dr. Kandil versus another?
Oh, yeah, definitely. I mean, like I said, he's very soft-spoken, very kind, and wants to explain things to you, and always has somebody with him learning by his side, you know, and that speaks volumes, I think. But, and I will say this, if anybody is watching this and they're afraid of it, don't be. It's not painful at all. You know, you wake up and you feel fine and no pain, and you go home.
Dr. Kandil, before we say farewell to everyone watching or listening, any kind of final thoughts?
I think patients should really explore their options. There are different options that are currently available. They are novel, they are new. It takes a while for the medical community to accept new interventions and novel technologies. But this is not investigational anymore. This is very well studied. This technology has been out there for a couple of decades outside the United States, and we've been doing this in the US for 5 years. And patients deserve and have the right to know their options. And you know, still some patients require to have surgery, and surgery is the only option. But many others do not need an operation.
Just a footnote before we say farewell to everyone. How many thyroid ablations have you done?
I think we are over 1,200 cases at this point, yes.
It's a lot.
So we've done the most in North America.
It's interesting. I think for you, you're really the pioneer in the U.S., one of the first, if not the first, to offer thyroid ablation.
Yeah, we started in 2020.
Mm-hmm.
Yeah, and it just got very busy.
Mm.
We were one of the first centers that started this in the entire country, and you know, people across the entire country knew about it or heard about it, and as I said, the vast majority of our patients are actually out-of-state patients. Yeah.
Susette, any final thoughts before we say farewell?
If you have thyroid problems, see Dr. Kandil.
Well, thank you.
I probably won't get an appointment because he'll be too busy.
I really appreciate it. But the key is really for patients to understand that they do have options.
Yeah.
Yes,
And they need to have second opinions.
you have options.
For those of you watching, for those of you listening, all the contact information for Dr. Kandil will be in the description to this episode. Say farewell to everyone.
Thank you.
Thank you,
Thanks, Susette.
Philip.
Thank you.
Thank you.
Thank you.